combined transvaginal and transabdominal oocyte retrieval in a patient with an ectopic ovary and unicornate uterus. An ectopic or undescended ovary is a rare gynecologic condition with an estimated prevalence of 0.3 to 2%. It is frequently associated with unicornate uterus and Mullerian agenesis. In up to 65% of patients, the ectopic ovary is visualized in the upper abdomen. Oocyte retrieval in patients with normal pelvic anatomy is facilitated by the growth and descent of the ovaries during ovarian stimulation, thereby decreasing the distance between the lateral vaginal walls and the follicles. In contrast, retrieval of oocytes from an ectopic ovary located in the abdomen may be extremely challenging or not possible through the transvaginal route due to the presence of vital pelvic structures. In this context, we report the utility of combined transvaginal and transabdominal oocyte retrieval in a patient with an ectopic ovary and unicornate uterus. The current patient is a 35-year-old woman with a 6-month history of involuntary infertility. She reported regular menstrual cycles, and her ovarian reserve testing was normal. Transvaginal ultrasonography in the office was significant for a left ovarian cyst. The right ovary was not visualized. A hysterosalpingogram was performed, which showed a left unicornate uterus with a patent left fallopian tube. Given these findings, a MRI of the pelvis was performed. Transverse sections of the pelvis reveal a right ovary in the upper abdomen with an ovarian cyst. The left ovary with an ovarian cyst is noted in the left hemipelvis. The left unicornate uterus is also noted in the transverse images as shown here. Sagittal MRI images of the abdomen clearly show the right ovary in the upper abdomen close to the anterior abdominal wall. The unicornate uterus, left ovary, and the ovarian cyst are noted lower in the pelvis. We reviewed options of laparoscopy with bilateral ovarian cystectomy, intrauterine insemination, and in vitro fertilization. The couple chose to proceed with intrauterine insemination treatment but did not conceive. To optimize oocyte yield, especially from the right ovary, a laparoscopy was performed. An initial survey of the pelvis shows the left unicornate uterus and the left ovary with the cyst. Laparoscopic left ovarian cystectomy was performed in standard fashion. The right ovary was seen in the upper abdomen, halfway between the anterior superior iliac spine and the edge of the liver. There was limited mobility of the right ovary, due to which ovarian pexy could not be performed. Given the patient's anatomy, a retrieval of oocytes exclusively from the left ovary was discussed with her. We discussed the possibility of transvaginal retrieval of oocytes from the right ovary if the right ovary showed descent into the pelvis during ovarian stimulation. Finally, we also discussed a combined transabdominal and transvaginal oocyte retrieval plan, that is, transabdominal retrieval of oocytes from the right ovary and transvaginal retrieval of oocytes from the left ovary. The patient underwent ovarian stimulation with an antagonist protocol. 2 follicles were well visualized in the left ovary. The right ovary and its follicles were well visualized via transvaginal ultrasonography. However, the presence of intervening blood vasculature made a transvaginal oocyte retrieval of the right ovary unsafe, if not contraindicated. The right ovary and its follicles were also well visualized via transabdominal ultrasonography. In contrast to the transvaginal route, the transabdominal route gave us direct access to the right ovarian follicles. We decided to proceed with transvaginal retrieval of oocytes from the left ovary and transabdominal retrieval of oocytes from the right ovary. The patient was counseled about low or no oocyte yield, especially from the right ovary, longer retrieval time compared to transvaginal oocyte retrieval, the possibility of abdominal pain, infection, hematoma, as well as injury to the abdominal wall muscles, blood vessels, peritoneal bleeding, urethral injury, as well as the likelihood of undergoing more than one oocyte retrieval. Our abdominal retrieval setup consisted of an oocyte aspiration needle, 16 gauge, 30 centimeters, a needle guide, a transabdominal probe with a biopsy guide, and a sterile probe cover. The angle of needle entry can be adjusted by the notch present on the biopsy guide. Following the attachment of the biopsy guide, the needle is passed through the needle guide for retrieval. The combined abdominal and vaginal retrieval was performed under conscious sedation in dorsolathoremy position. A abdominal and vaginal prep was performed. The operator was positioned in between the patient's feet. The vaginal portion of the retrieval was performed first, followed by the abdominal part. The patient underwent 2 IVF cycles. In the first IVF cycle, 7 oocytes were retrieved transabdominally from the right ovary, and 2 oocytes were retrieved transvaginally from the left ovary. All oocytes were mature, and 5 blastocysts were cryopreserved. In the second IVF cycle, 5 oocytes were retrieved transabdominally from the right ovary, and 3 oocytes transvaginally from the left ovary. All oocytes were mature again, and 4 blastocysts were cryopreserved. A single thawed embryo was transferred in the natural menstrual cycle. This resulted in the birth of a full-term baby boy weighing 2410 grams delivered vaginally. Previous studies have attempted to classify ectopic or undescended ovaries into 3 categories: post-surgical implants, post-inflammatory implants, or true embryologic. Post-surgical implants are associated with prior surgical resection of cysts or tumors from a lobulated ovary. Post-inflammatory implants are related to torsion or autoimputation and revascularization of the ovary. Patients with true embryological ectopic ovaries have no pertinent gynecologic history or pelvic pain and usually have other Mullerian issues. One embryologic mechanism underlying undescended ovaries could be the lack of caudal descent of the gonads into the true pelvis. An ectopic ovary can be suspected when there is a discrepancy between estradiol levels and follicular growth in one ovary, or the non-visualization of the other ovary. Diagnosis of an ectopic ovary can be achieved by ovarian stimulation, abdominal ultrasonography, magnetic resonance imaging, or laparoscopy. Retrieval of oocytes from an ectopic ovary should be determined by the antral follicle count in that ovary and the access to that ovary either transabdominally or transvaginally. A study of 69 transabdominal oocyte retrievals, which included 12 cases of combined transvaginal and transabdominal oocyte retrievals, reported no statistically significant differences in IVF outcomes were observed in this study. In conclusion, the current case reports the detailed fertility management of a patient with an ectopic ovary and unicornuate uterus.